The culmination of all uncomplicated phacoemulsification surgeries is implantation of foldable intraocular lens into the capsular bag. Proper loading of the lens into the cartridge and proper implantation technique is of paramount importance in ensuring that an undamaged lens goes into the capsular bag. In the vast majority of cases, this result is achieved, but once in a while, there can be damage to the optic or to the haptic of the lens, which requires removal and lens replacement. In this video, we are going to demonstrate a few instances where we had to remove the intraocular lens. In this particular case, the trailing haptic has broken and this lens will be unstable in the capsular bag. The leading haptic is slowly exteriorized and the lens is transected inside the eye under good cover of cohesive viscoelastic. Even though the lens is not fully transected, the lens can easily be maneuvered out through the clear corneal wound without extending the wound. This is another similar case of a small pupil phaco where iris hooks have been used. In this case, we could transect the lens successfully inside the anterior chamber and each piece is removed separately. Care has to be taken to coat the endothelium and also to keep the posterior capsule far away from the maneuvers by using copious amounts of cohesive viscoelastic. This was a hydrophobic acrylic lens where one haptic broke, and here we are attempting to do the same transection of the lens inside the anterior chamber. Certain lenses slip during the transection and it is quite often not able to achieve the transection. Here, the lens is slowly maneuvered out of the eye, but the lens is getting stuck at the corneal wound. One can cut the open part of the lens and then put cohesive viscoelastic again into the anterior chamber and remove the rest of the lens. Again, care has to be taken not to injure either corneal endothelium or the posterior capsule. This was another hydrophobic 3-piece lens where one haptic broke. These lenses are quite often difficult to transect within the eye because the scissors slips over the slightly thick haptic of such lenses. Moreover, the haptic which is inside the eye can damage the posterior capsule. Here we are hinging out the lens from inside the anterior chamber, but again the lens is getting stuck at the clear corneal wound. Without damaging the wound, the lens is transected and easily removed. Here was another 3-piece hydrophobic lens where the haptic has got bent inside the eye, and in such situations, care has to be taken that the haptic does not injure the posterior capsule. The haptic has got separated from the optic while the lens was removed, and now the haptic is slowly taken out from the anterior chamber. In this scenario, hydrophilic acrylic lens has got damage inside the eye. Here, the optic is mainly damaged. If one is unfamiliar with transecting lenses inside the eye, it would be a safe option to just enlarge the corneal wound and remove the lens in toto and replace with another lens and securing the wound with a few sutures because this is a clear corneal wound. In this video, we would also like to demonstrate the normal safe loading and injecting techniques of a few commonly used lenses. This is a commonly used hydrophobic acrylic yellow colored lens. The surface of the lens has to be coated well with viscoelastic and care has to be taken while holding the lens to load it into the cartridge. While loading, the leading haptic has to be hinged against the surface of the cartridge so that it bends upon the lens, and the trailing haptic is also inserted above the lens in a similar fashion so that both haptics are now folded over the optic. The lens thus folded is pushed to the cartridge to make sure that the haptics do not unfold. This ensures a safe implantation of this particular lens. Before implanting the lens into the eye, make sure to visualize the entire lens through the cartridge till the tip of the cartridge to ensure that the lens is not damaged before it is implanted into the eye. This is another hydrophobic acrylic lens which is preloaded in the cartridge. One just has to fill the chamber with viscoelastic and push the lens through the cartridge into the anterior chamber. But again, this lens has to be visualized to make sure that the lens is not by any chance damaged in the preloaded cartridge. This is another acrylic lens where a small opening is provided for injecting the viscoelastic into the cartridge. The safety lock is removed and the lens is slowly threaded through the cartridge till the tip. The screwing motion ensures the lens slowly moves through the cartridge and does not get damaged during implantation. Moreover, it gives better control for implantation into the eye and the lens goes slowly into the capsular bag. This is a 3-piece hydrophobic acrylic lens which is injected through this injector, which is again a screw type injector, so that the lens moves slowly into the capsular bag. One had to check the integrity of the plunger before the lens is loaded. Like in any cartridge, the chamber is filled with viscoelastic material. The surface of the lens can also be coated with proper amount of viscoelastic material so that no damage occurs to the surface of the lens. The leading haptic goes into the chamber and the trailing haptic has to be tucked by the side of the small knob provided here so that the plunger does not damage the trailing haptic. Again, the lens is loaded and one has to visualize the lens as it moves through the cartridge and make sure that no damage has occurred to the lens before it is implanted into the eye. The blue PMMA haptic can be visualized through the transparent cartridge. This is a hydrophilic acrylic lens which has to be loaded into the cartridge. The cartridge is filled properly with viscoelastic. The lens is placed in the chamber and care has to be taken to see that both the optic and haptic has gone under the flanges before it is closed properly. If either the optic or the haptic gets caught inside the flange, the lens can get damaged while the lens is being pushed for implantation. Again, visualize the lens entirely outside the eye and ensure the lens is okay. This is another hydrophobic acrylic lens which is placed inside the cartridge. The optic is first tucked inside and both the haptics are placed above the optic in a fetal position so that the haptics do not get damaged during implantation. More and more intraocular lenses are now available in a preloaded fashion which takes away many of the difficulties of loading the lens inside the cartridge. Proper care has to be taken during loading the cartridge and implantation of the lens into the capsular bag. Proper visualization at every step is of paramount importance in order to prevent damage to the intraocular lens. If ever a lens gets damaged, a proper technique has to be used to remove the lens without enlarging the existing clear corneal wound and replacing it with an undamaged lens. So, we end by saying, even you have a broken lens, your promise of good vision to the patient remains unbroken.